Good morning, everyone. Myself, I'm Divya, second year postgraduate from GEMS. I'm going to present a paper on clinical study of lens-induced glaucoma at GEMS in Hospital, Ragolu. Financial disclosure and no conflicts of interest. Lens-induced glaucoma, it was first described in the year 1900 by Gifford and Vondius independent of each other, while the former described it as glaucoma associated with hypermature cataract and later described it as glaucoma associated with spontaneous absorption of lens substance through intact capsule. It is a common entity presenting to the outpatient department as an acute painful diminution of vision with red eye. Late reporting for treatment of cataract has led to serious complications like LIG. It remains one of the most important cause of irreversible vision loss in rural areas. This preventable and curable condition, though rare in developed countries, it is unfortunately still prevalent in India. It is a clinical condition characterized by a secondary glaucoma in one eye with senile mature cataract or hypomature senile cataract or immature senile cataract with an open angle, and normal intraocular pressure and open angle in the other eye, and a prompt relief from symptoms and restoration of vision after cataract extraction in the affected eye. Based on the pathogenesis, it is further classified as open angle or lens protein related. There are phacolytic glaucoma, lens particle induced glaucoma, and phacoanaphylactic glaucoma, and closed angle or aqueous outflow obstruction, which is a phacomorphic glaucoma, and pupillary block glaucoma, which can be due to ectopia lentis. It may be congenital or acquired. The study emphasizes on the importance of early diagnosis, patient education, frequent and regular surveillance of all cases of cataract, which go for hypermaturity and early surgical intervention. Objective to study the demographics, clinical presentation, and management of lens-induced glaucoma. Materials and methods. It is a prospective study of 38 patients with LIG presented from September 2022 to May 23, who presented to ophthalmology OPD at Jameson Hospital. Inclusion criteria: patients presenting with phacomorphic glaucoma, phacolytic glaucoma, lens particle glaucoma, and phacoanaphylactic uveitis with secondary glaucoma, and glaucoma secondary to ectopia lentis. Exclusion criteria: cases of primary glaucoma associated with cataract. Methodology: detailed history and thorough ocular examination using slit lamp was done in 38 patients, and IOP was recorded by applanation tonometry. After intraocular pressure control done with medical management, gonioscopy done, and surgical management was planned according to the need. Prognosis was explained to the patient, and surgery was done after taking the consent of the patient. Postoperative care was taken, and thorough postoperative evaluation of posterior segment was also done. All the results were statistically evaluated. Results: sex distribution among the 38 cases. Females were about 68% with high predominance and than males, which accounted for 32%. Age: maximum patients were from the age group of 70 to 80 years, about 45% of the cases. Youngest case in the study was 51 years old and the oldest was 81 years old. Duration of symptoms: main clinical symptoms were eye pain in 94.2% cases and redness in 85% of the cases, associated defective vision. Cases presented within first week are 55%, within second week are 26%, and more than 3 weeks are 18%. Status of the fellow eye. The fellow eye of the patient, 55% of the cases are pseudophakic, and in 26% it is with immature senile cataract, and in 16% it is mature cataract, and in 3% it is aphakia. Etiological diagnosis: about 74% of the cases of phacomorphic glaucoma, and 21% of the cases of phacolytic glaucoma, and in 5% it is due to ectopia lentis. These are the images. First image is phacomorphic glaucoma, hypermature glaucoma cataract, and phacolytic glaucoma, and it is ectopia lentis due to anterior subluxated lens due to trauma. Intraocular pressure: most of the cases, highest percentage of 55% were noted in the range of 40 to 49. On immediate post-op and during discharge, IOP was recorded, and highest percentage were between 10 to 19 millimeters of mercury. Plan of management: after intraocular pressure control with medical management, surgical management was planned. In 63% of the cases, SSCS with PCIOL was done, and in 32% of the cases, cataract extraction combined with pars plana vitrectomy and SFIOL was done, and in 5% of the cases, combined procedure, that is cataract plus trabeculectomy was done. Visual acuity: on admission, most of the patients were HM positive to PL positive. On the day of the discharge, 53% of the cases were seen between 6/24 to 6/36, followed by 6/12 to 18 in 29% of the cases, and less than 6/16 in 18% of the cases. This drastic shift of visual acuity from HMs to PL positive to better than 6/60, 1/60 during the discharge was noted. When the patients came back for follow-up on 6th week, again improvement of vision was seen in majority of them. Discussion: LIG is a condition to be taken into account in our ophthalmic patients, especially in our rural area. In spite of easy availability of surgical facilities, cataract surgery being cost effective and rewarding surgery, many people are becoming blind due to lack of awareness. Illiterate, old and rural populations are the worst affected. In this study, female predominance is seen. Similar results were seen in Venkatesh Pragna et al. And Raghunandan Kothari et al. And phacomorphic glaucoma accounts for the highest percentage, which is seen in Venkatesh Pragna et al. And Raghunandan Kothari et al. And phacolytic glaucoma more seen in advanced stage, similar to Spector et al. And Zerzing et al. And IOP prior to surgery was high. Post-surgery, IOP was reduced in 81% of the cases, seen in Jacob et al. And Raghunandan et al. Visual outcome better than 6/36 in 82% of the cases in this study. And similar study results in Venkatesh Pregna, 51% of the cases had vision better than 6/18. This study, 13% of the patients got no visual improvement, only marginal improvement is seen in the vision after surgery. This was the group where there is a lag between development of symptoms and the reporting for treatment was the longest. Late reporting was emerged as important causes. And associated pathologies were also seen in cornea, involving cornea and corneal opacity and macula. That is, macular scar was seen in a few cases. Conclusion, it is a vision-threatening disease presenting as a painful red eye. Most important cause of blindness, not only due to senile cataract, but also due to glaucomatous optic atrophy. Even after the advanced surgical techniques and immense efforts by National Program of Control of Blindness, lack of awareness in rural population and good vision in fellow eye, causing them to remain with cataract lens for a prolonged period. These are my references. Thank you.
Your inclusion criteria for lens-induced glaucoma. So here there is no mention of posterior segment evaluation. You already mentioned that 2% there was no vision recovery because of macular scar. There is no documentation of evaluation of the posterior segment in any of your cases. Especially subluxated lens, you can evaluate the posterior segment, isn't it?
Yes,
there is no mention of that. So an attempt should be made, even if in lens-induced glaucoma, B-scan can be done to evaluate the posterior segment. So you have not recorded the IOP after the cataract surgery?
Recorded.
You have recorded?
Yes, sir.
There was no mention of that?
Mentioned, sir. POD 1 and on discharge.
Can you go back to your criteria slide? Previous one. Previous slide. Previous one. Previous one. So, is this how you defined LIG in your study?
Yes. It is a secondary glaucoma with.
No, you have read normal IOP with.
In the other eye, ma'am.
So, what about phacomorphic glaucoma?
Phacomorphic glaucoma, IOP is raised in the same eye.
How will the angle be? Will it be open?
It will be shallow, closed, ma'am.
Shallow or what do you mean by shallow angle?
Shallow anterior chamber and angle will be closed.
So we cannot conclude all LIGs have open angles.
Okay.
Right? And on what basis did you do? Did you decide whether you had to do cataract or cataract plus trab?
Presentation, regarding presentation, and if there is a chronic presentation and presence of synechiae are present, then after reduction of intraocular pressure, gonioscopy was done and angles were assessed, ma'am. On the gonioscopy findings, trab was done in few cases.
So when was the cataract done? After how many days after presentation?
After reduction of intraocular pressure, ma'am, within 2 days it was.
So the cornea cleared in 2 days and you have done gonio and then you have decided whether you should do cataract or whether you should do cataract plus trab?
Yes, ma'am, in early presented cases.
So that should also have been included in your methodology.
Okay.
On what basis did you decide whether you should do only cataract or you have done a combined surgery?
Okay.